Hello, everyone. I hope you're enjoying this hot summer. I'm glad you were able to attend our fourth pathology resident-led live unknown slide session, or PRLUSS, as I like to call it. Today, my former colleague and dear friend, Aminia Ciobonoiu, who is a PGY5 anatomic pathology resident at the Oncologic Institute in Bucharest, Romania, will be walking us through papillary lesions of the breast. Aminia has picked for us a series of textbook-like examples of these entities, and I'm sure that by the end of the session, she'll be able to break down this complex topic into more digestible pieces for us. First of all, I would like to discuss with you some housekeeping items. We're going to take a summer break in August, and we'll be back sometime in the first half of September. The exact date remains to be determined. I'll let you know. With our next regular meeting, which is going to be on pink renal tumors, part 2, as promised, with a special focus on molecularly defined renal cell carcinoma. Lastly, for those of you who are new and watching on YouTube, this is a recurrent meeting, which is meant to represent an opportunity for us residents to get together and learn from each other in a very benign, friendly, and informal environment, as you can notice. I encourage everyone, regardless of your training level, even if you're a pathology aspirant, like not a pathology resident as of yet, to volunteer to present something as part of this format. I think it's a good opportunity for you to, for us all actually, to practice our presentation skills for future bigger events. And my contact info can be found in the info box of the video. So without further ado, I'll pass the microphone to Aminia.
Okay, thank you. Hello, everyone. My name is Aminia Ciobonoiu. I'm a fifth-year pathology resident in Bucharest, Romania. I will be talking about papillary lesions of the breast. Come on. Okay. Before we start talking about the cases, I want to look at this picture, at this image. We see here 4 papillary lesions, intraductal papilloma, papilloma with atypical ductal hyperplasia and DCIS, papillary DCIS, and encapsulated papillary carcinoma. In intraductal papilloma, we see myoepithelial cells both at the periphery of the lesion, as we see here, and also in the fibrovascular course. In the papilloma with ADHD and DCIS, we see myoepithelial cells in the periphery and in the fibrovascular course, but we don't see myoepithelial cells in the areas where the papilloma is involved by DCIS or ADH. In papillary DCIS, we see myoepithelial cells only in the periphery of the lesion, so in the stalks we don't see them, and in the encapsulated papillary carcinoma we don't see myoepithelial cells. Regarding the hormone receptors, in intraductal papilloma, estrogen is positive with a patchy or mosaic stain. In areas with ADH or DCIS, estrogen is diffuse and strong positive, also in the papillary DCIS and encapsulated papillary carcinoma. So let's dig in our cases. The first case is a 77-year-old female that had a cystic lesion measuring almost 2 centimeters with an intracystic 9 millimeter papillary proliferation. On low power, we see the cystic dilated space with the papillary proliferation. On low power, we see a lot of pink. We have broad fibrovascular cores. They are kind of sclerotic, hyalinized, with small vessels, and we see the proliferation of the epithelium. The cells are not really monomorphic. They look irregular. The nuclei are overlapping. We see slit-like spaces here, or on low power, we see them better. So what we do next, we do immunostains. We used P63. So we see that myoepithelial markers are positive in the fibrovascular course along the epithelium. And it was also positive in the periphery of the lesion. So here we can talk about papilloma, but the epithelium is kind of crowded, proliferated. So estrogen was patchy positive, so only a few cells were positive for it. We did 34 beta E12 or CK903, which was diffusely positive. We use this marker to differentiate between usual ductal hyperplasia, which is positive, and a typical ductal hyperplasia in DCIS, in which cases it's negative. So here is diffusely positive, as you can see. So we can talk about usual ductal hyperplasia in an intraductal papilloma, an intraductal papilloma with florid UDH. So again, we have broad fibrovascular cores. Like I said before, they can be sclerotic. If we talk only about intraductal papilloma, these fibrovascular cores are covered by myoepithelial cells and epithelial cells. When we talk about UDH in a papilloma, cells are irregularly arranged, and we see those slit-like spaces. So ER, estrogen, and CK5-6 is patchy positive, as we had in our case, and 34 beta E12 is diffusely positive. Next case, we had a 51-year-old female with a retroareolar mass measuring almost 5 centimeters. Again, we see a cystically dilated space. Again, within this dilated space, we see papillary proliferation. Here we see a fibrovascular cord with sclerosis, but the epithelium is kind of blue, is again proliferated. We see some punched out spaces or round spaces, and when we look closer, we see the cells are arranged around these spaces. Again, we stained it with myoepithelial marker, and they were positive in the periphery of the lesion, but also in the fibrovascular course. Estrogen was strong and diffuse positive, so we don't talk about usual ductal hyperplasia here. Our first thought was it's a typical ductal hyperplasia in an intraductal papilloma, but In the WHO Blue Book, it says that if the area of the atypical ductal hyperplasia in a papilloma exceeds 3 millimeters, so is larger than 3 millimeters, we can name it a DCIS. Outside the papillomas, the cutoff is at 2 millimeters. So if we have ADH measuring more than 2 millimeters outside the papilloma, we can call it DCIS. So here it's intraductal papilloma involved by DCIS. Next case. We have a 71-year-old female with a breast mass. Again, we see a cystically dilated space with the papillary proliferation within. Again, on low power, we see a lot of blue cells. So the fibrovascular cores are not absent, but are a little more delicate. When we look closer, we see the cells again are arranged around those punched out spaces very smoothly. And the cells, the nuclei are low grade. When we performed myoepithelial markers, we see positivity only in the periphery of the lesion. In the fibrovascular course, they were negative. Estrogen was intensely and diffusely positive. So here we talk about papillary DCIS. This is a pattern of DCIS. As we mentioned before, the cells are in general low grade. Sometimes the epithelial proliferation may fill completely the duct, so it becomes more cribriform or solid. Comedonecrosis is infrequent in comparison with the other patterns of DCIS. And we can see globoid cells. These cells are epithelial cells. They have the same atypia as the epithelial cells in the DCIS, but they have clear abundant cytoplasm looking like myoepithelial cells. Again, estrogen is strong and diffuse positive, and we see myoepithelial cells only in the periphery. Next case is a 71-year-old female with a 5-centimeter mass in the upper left breast. Again, we see some cystically dilated spaces. This time we see a thick fibrous capsule around the lesion. We have papillary proliferation. We don't really see the fibrovascular cores. We see this area. We'll talk about it a bit later. When we look closer, again, we don't see fibrovascular cores. They are very delicate. The cells are monomorphic. Sometimes they are hyperchromatic nuclei. P63 was negative in the periphery and in the proliferation. And estrogen was intense and diffuse positive. So here we talk about encapsulated papillary carcinoma. This type of lesion acts and is graded as carcinoma in situ when invasion is not present. Sometimes invasion is present in form of invasive breast carcinoma of no special type, or lobular carcinoma. Now, let's go back at the first picture. We see this area here. We see tubules and cords of tumor cells. So this area is the area of invasion. As a differential diagnosis, we have this lesion. We have a solid nodule with smooth contours. It looks similar to jigsaw puzzle. When we look closer, we see delicate fibrovascular cores and some necrosis. The cells are larger, and the cytoplasm is eosinophilic and granular. They look like neuroendocrine cells. This is a solid papillary carcinoma. Again, this is staged as carcinoma in situ when no invasion is around it. This tumor is estrogen positive, and you can perform neuroendocrine markers. They are usually positive. Sometimes extracellular mucin may be present, and it can be associated with invasive breast carcinoma of no special type, lobular carcinoma, or mucinous carcinoma. Before we go to the fifth case, I want to emphasize something. When you see encapsulated papillary carcinoma or solid papillary carcinoma with invasion, you don't call it papillary invasive carcinoma. It's an encapsulated papillary carcinoma or solid papillary carcinoma associated to invasive breast carcinoma of no special type, or other carcinoma that is present. So don't call it invasive papillary carcinoma. Also, you must be careful, because these lesions, when they are biopsied, needle epithelial displacement may show up. When a biopsy is performed, some tubules or cell nests could get seeded along the needle tract, looking like invasion. So you have to know the history of the patient, but also on microscopy, you will see a linear row of tubules or nests surrounded by inflammation, hemorrhage, and sometimes fat necrosis. And the last case, It was a 47-year-old female with enlarged lymph node. So on low power, we see the lymph node, and it has some desmoplasia and necrosis and an epithelial proliferation. When we look closer, we see some mildly dilated ducts with a papillary proliferation. We thought of tumors that look papillary and could invade this lymph node. So we thought of ovary, lung adenocarcinoma, or even thyroid papillary carcinoma. We performed immunostains. So CK7 was diffuse positive, TTF1 was negative, GATA3 was positive, hemoglobin was positive, hormones were positive, HER2 was hormones were negative, HER2 was positive. So it was breast tumor. Indeed, the patient had a breast mass in the left breast. So we could say this was an invasive papillary carcinoma. This type of tumor is extremely rare. When you see, even in the breast, when you see an invasive papillary carcinoma, you don't think first that it's an invasive papillary carcinoma originating in breast. You think first that is metastasis. It should have over 90% or more over 90% papillary architecture. In general, estrogen is positive, HER2 is negative. We had estrogen negative and HER2 positive. In literature, there are cases with hormone negativity and HER2 positivity. In the end, I want to talk again about myoepithelial markers and hormone receptors in the papillary lesions. So in intraductal papilloma, myoepithelial markers are positive in the papillary front, so in the fibrovascular course, but also in the periphery of the lesion. In papilloma with the ADH or DCIS, myoepithelial markers are absent in the areas involved by ADH or DCIS, but are present in the periphery. In papillary DCIS, myoepithelial markers are only positive in the periphery, and in encapsulated papillary carcinoma, solid papillary carcinoma, in the invasive papillary carcinoma, they are in general negative. Thank you very much.
Great, Aminia. That was a great presentation. Could you shortly
Yes.
pass the host properties to me, please?
Yes.
So, like, I would just like to add two stuff, some things like, my a quick summary, key points that I would like to take home, for example, from your presentation. So we've seen myoepithelial markers are very helpful, are essential in distinguishing between these lesions. Apart from appreciating them on H&E, like you said, encapsulated papillary carcinoma usually has a pushing border. It has this thick hyalinized collagen that kind of forms a pseudocapsule around it. So apart from appreciating that, myoepithelial markers are very useful. And if you remember that schematic with myoepithelial markers at the periphery of the lesion and inside the lesion along the fibrovascular course, present or not, you're gonna be able, in most instances, coupled with other immunohistochemical assays, I'm gonna talk about it really quick now, you're gonna be able to distinguish between these lesions. One, I'm sorry I don't have the case to show, but we had a case recently where we had an extensive DCIS, and part of it was papillary DCIS, and then we had a lesion that was adjacent to this DCIS area that looked on H&E looked pretty encapsulated, well circumscribed, and it had this sort of hyalinized stroma around it. It was papillary, and the first impression was it had a low-grade area, but also had transition into more high-grade areas. So first thought was like, could this be an encapsulated papillary carcinoma? But this turned out to, so it lacked myoepithelial cells at the periphery and inside. And but the thing is, it turned out to be a triple negative carcinoma. And it also had, like I said, it had that high-grade nuclear features. At least part of the lesion had high-grade nuclear features. And this is one thing to take home. Encapsulated papillary carcinoma has low to maximum moderate nuclear atypia, and it's usually of the luminal A type. Like, it expresses ER/PR. It's not going to be a triple negative carcinoma, and it's not going to be high grade, and that's not going to be screaming pleomorphism at you. If you see something that looks like this, and the WHO recommends that you diagnose or you classify these sort of tumors as invasive breast carcinoma, NST, or something else. So you steer away from encapsulated papillary carcinoma. But I'm sorry, I don't have the images to, show this. Another important thing with encapsulated papillary carcinoma, one differential would be solid papillary carcinoma. It helps to know that solid papillary carcinoma is one of those breast cancers that most frequently shows neuroendocrine differentiation. So it will express synaptophysing chromogranin, whereas encapsulated papillary carcinoma will not. And apart from that, I think this is it.
I have a question for you. How many markers do you use for myoepithelial cells in a
We
case?
have a combination. We don't have calponin, for example. People in the US, I've seen they usually do calponin. We have a combination, mixed antibody, a cocktail of antibodies where we use CK5 and P63. So you're gonna have the high molecular weight cytokeratin, which is gonna stain the cytoplasm, and you're gonna have the nuclear marker. So like it works pretty good. But I haven't seen it, I mean, in most places I've seen them used separately, not as a cocktail.
So what's your experience with smooth muscle myosin heavy chain? And
we don't have it.
No.
We don't have smooth muscle myosin heavy chain. We don't have it. We don't have calponin. But like I said, we do see a lot of breast pathology, and CK5, this combination of CK5, P63, but of course, even if you have them separately, you can use them as that. They work pretty fine, pretty good for us, at least. Yeah, so I think that's just about it. I had a case. I was thinking while you were talking if I can show it, but it's in the differential. It's an extremely rare tumor, cyst adenocarcinoma, mucinous cyst adenocarcinoma of the breast. It's one of the differentials is encapsulated papillary carcinoma. When you see that,
I remember that one, right? I think you posted it on Twitter.
Yes, I did.
I remember that day, and I was like, wait, I need to take notes on this. Like, I haven't seen this ever in my life, and I've spent quite some time seeing breast pathology, but that thing I've never seen, and I was so intrigued when you posted it. So yeah. And I wanted also to say thank you, Aminia, for this comprehensive presentation on papillary breast lesions. For me, it was like a really, really sweet moment to remember those kind of lesions. I haven't seen breast pathology in a while, and it was nice to go through those with you. And thank you. And I have to say, I really appreciate the pictures that you took, and overall, it was a great presentation. So thank you.
So Ioana, it's not just for you, you know, that tumor, so mucinous cyst adenocarcinoma of the breast is extremely rare. Like when I was in the US, there was Dr. Wei is a expert on breast pathology, and he was saying that he hasn't seen, I mean, he saw just one in his entire career, and that one was a case of a colleague. So it's like that. I was thinking about, I quickly checked if the morphology was like similar to encapsulated papillary carcinoma, because I was thinking about showing it, but it's on Kiko anyway. I'm gonna share the link if you want to see it, but it mostly resembles, like the one that we had mostly resembles mucinous carcinoma, so it wouldn't fit with the topic. Yeah, but otherwise I think that's just things to remember about papillary lesions of the breast, right? Myoepithelial markers, regardless of what you use, right? Because
I think it's just important to do them, just do them and sleep well at night, then just have a guess on H&E. Sometimes it can be really troublesome.
Yeah, you start from the H&E, and then you go on and you know, and that's another thing about encapsulated papillary carcinoma. I mean, I mentioned it has a very good prognosis. So that's why when it is not associated with invasion, it is staged as an in situ lesion, essentially. It's staged like a DCIS. And if you have associated invasion, you're going to stage only that invasive component. So you're not going to, for the measurement, you're not going to take in the measurement, the encapsulated papillary as carcinoma as well. You're just going to regard the invasive component, which is usually, like she said, an NST, but it can also be something else, like a special subtype of breast cancer. And I think that's about it. I don't know what I can add more than that. Oh, and last thing to remember, like I'm just saying stuff that maybe for some people this is like obvious stuff, but for me it's like I try to you know, to repeat this stuff for me so that I can remember. It's like the cutoff for DCIS within an intraductal papilloma is different than that for an atypical ductal proliferation. Or ductal proliferation, not hyperplasia or stuff outside of an intraductal papilloma. 3 versus 2. So it's
like what a difference 1 millimeter can make. It's amazing, right?
Yeah. Well, these cutoffs are like essentially they're arbitrary, like in other organs as well. So they're based, they're based on studies, but you don't have to, like, they may change. In other organs, we have seen this, like cutoffs do change with new knowledge, with accumulating literature, right? So remember this different cutoff, the 3 millimeters versus 2. And also remember that in a intraductal papilloma, you don't add different areas of atypical proliferation to reach a 3 millimeter cutoff. You have to have a continuous proliferation. You measured it, it's above 3, it's 3 or above, you're fine with DCIS in an intraductal papilloma. If not, you don't add them up and come up with, I don't know, 3 point something millimeters, right? And I think this is about it. Thank you so much, Aminia. This was great.
Thank you very much. It was great, guys.
Yeah. Hope to see you in September. Enjoy your summer, and I expect other people to volunteer. Let's do this. It's fun. Let's talk about pathology. We all like it. Okay. Glad to see you all. Have a great summer. We'll be back in September.
Thank you. Goodbye.
Bye-bye.